All right, perfect. All right, so good morning, guys. I'm going to be doing Neuropath today. So we'll start with right in with case one. Case one is a 60-year-old male, no past history, actually presented to Bascom after about 3 weeks of progressive visual decline, to the point that he just had hand motion and was unable to count fingers. They were told to go to the ED a few days ago when they had seen at Bascom, when they had been seen at Bascom, but didn't. They delayed until the day they presented to us. On exam, the patient, outside of having hand motion bilaterally and unable to account, was neuro intact. Here is the ophtho exam. Here we see both hand motion bilaterally, and we also see grade 5 papilledema in both eyes on their optic nerve exam. So who do we have here? I guess we have Turkey. You around, man?
I am.
Oh, perfect, man. So tell me what you see here, sequences and what image study and what you're seeing.
Yeah, so this is an MRI, axial, coronal, and sagittal with contrast. And I can see that there is a large extraaxial enhancing lesion at the parietal, area with some edema, at the cortex, physiogenic edema.
Mm-hmm.
It seems like, more like a meningioma.
Okay.
Yeah.
Okay. All right. Yeah, exactly. So like you said, broad base, other things, dural tails you're seeing. Then what am I showing you here?
Yeah, so there's, a large physiogenic edema with compression of the, the lateral, the right lateral ventricle, especially, the posterior part. I see some like CSF tumor interface, so it seems like
great.
Yeah,
that's what I was trying to get at with that T2 on the left, and then the flare sequence on the right, the edema and some of that that CSF signal between the tumor brain interface. So how about here? What are you seeing here?
Yeah, so there's like optic nerve. I guess it's like, instead of that smooth looking optic nerve, it seems like it's more, there's like high pressure, high ICP, so that's why it seems distorted, I'd say. And also you have the optic nerve sheath. You can see like CSF there, so it seems like this is an indication of high ICP, and also the optic disc is kind of bulging.
Yep.
Yeah.
Perfect. And the only other thing I would add to that is the cella. The cella was empty. I know it's better seen on the sagittal, but they didn't really have a sagittal for me to be able to show you. So empty cella as well. So exactly what you're saying. So what would you do for your next steps here? You got a guy, 50, 60 years old, relatively rapidly declining vision over the last couple of weeks, signs of high ICP on imaging, and a large space occupying lesion. Not an extremis.
Yeah, so definitely this needs to be resected, given that it's progressive. It's causing progressive visual loss, high ICP. This needs to be taken out. Yeah, my next step is just to take it out. It's in a non-dominant hemisphere. It seems to be posteriorly located, so I wouldn't do awake surgery, just simple craniotomy. I have the MRI with fiducials.
Okay.
Yeah, no complicated neurophysiology.
Any temporizing measures? Say this came in the middle of the night. You don't need to go right away, because I said the patient's not an extremis. Anything you would do to try to see if there's any improvement with vision?
Yeah. I might just give Diamox as a medical treatment. Okay. I think EVD is too much. I don't think it's causing any hydrocephalus. So.
Okay. Well, in this case, the decision was actually to place an EVD, given the papilledema and the visual decline. So that's what was done. And then I'll show you the scan real quick. Any additional imaging you would want for this, given location and such?
Yeah, I'm not really sure there's any other images that I would do for this, honestly.
Okay. On this axial cut, you kind of see kind of on the most medial aspect of the tumor, it's abutting what?
Oh, you mean MRV? Yeah.
Yeah, exactly, man. That's also what was done. Additional imaging was to get an MRV, and here it is. And I'm not a pro at reading MRVs, but what do you see? And the answer that it's normal is also a good answer too.
Yeah, I mean, I can see, it's a very difficult, I mean, do you have like another view, like more of
No, I honestly I don't. What I can tell you is that it's patent. I know like that at that transverse sigmoid junction is hard to tell. I tried to get the slice that would show it kind of the best angles of everything. Okay.
Yeah.
So patient, what's on your differential? You mentioned one of them. Anything else?
Yeah, so meningioma, meningoperitocytoma, could be a METS, metastatic lesion, could be also, even though it's not common, but leukemia, dural-based leukemia / lymphoma.
Yeah. So you hit basically the ones that I wanted you to hit. So that's the differential here. So patient here was taken to the OR. They underwent a right parietal craning. Obviously careful drilling near the sinus because it was abutting next to it. The dura was hypervascular, and actually in this case 5-ALA was used. I guess we have a clinical trial to look at it in patients who we think may have a meningioma to see what the role of that is. And in this case, the tumor, after they debulked it, was positive for 5-ALA in the middle of the tumor, and ultimately was able to have an en bloc resection. And now I'll let Dr. Saad show some of the pathology slides.
Thank you very much. Good morning, everyone. Okay. Oops. Okay. So this is the tumor at low magnification. Everything here appears to be meningioma. So you have the vague whorling growth pattern, which we often describe in meningiomas. The tumor cells appear to be epithelioid, and they appear to be meningothelial. And you can see some clearing of the nuclei, which is commonly seen in meningiomas. However, just next door to it, you start to see a different growth pattern. You have glandular or acinar structures, and the tumor cells appear to be different. They're larger, they have prominent nucleoli. And this is a picture where they are next to each other. So this is the meningioma, the whorling growth pattern, and next to it, you have the adenocarcinoma. So you can see the difference in cytologic characteristics. So this is napsin, which is a pan-lung adenocarcinoma marker. You see the meningioma is completely negative, while the adenocarcinoma is positive. We always like to do another pulmonary marker just to make sure. This is TTF1, which is commonly used in lung adenocarcinomas. Again, the meningioma is negative, while the tumor cells show this strong and diffuse nuclear staining. So this is a metastatic lung adenocarcinoma to a meningioma. And as you guys know, and James, you described it, that meningiomas are commonly hypervascular, and that's why they're magnet for any metastatic disease.
Can you hear me now? So once again, like Dr. Saad said, here's the diagnosis. And actually, postoperatively, a CT of the chest, abdomen, pelvis showed a lesion in the right middle lobe of the lung. So we hit on these things just now: the whorls of cells, the pneumoma bodies, the spindle-like nuclei that you see with a meningioma, and the napsin positivity for a lung adenocarcinoma. And in this case, Dr. Saad had mentioned they did the extra one, the TTF1, just to ensure that it was truly lung-based. So my familiarity with 5-ALA really revolves around gliomas, and I didn't know its role in meningiomas or in Mets. So just quickly, this paper actually shows that in this series of, I think it was like 80 or something patients, about 40% of patients in this series had either strong or faint 5-ALA, and 60% had no ALA in these metastatic lesions. But they did find that those patients that were 5-ALA negative actually had a significantly higher risk of local recurrence compared to those that were 5-ALA positive. All right. And just obviously when we're talking about meningiomas, here's the Simpson grading scale of going 1 through 5 in terms of the resection that was done and what was left in the boundaries. So hold on 1 second. Let me adjust this thing. All right. All right, case 2. Case 2, a 48-year-old male, history of HIV that's untreated, who presented after 1 week of left eye proptosis and blurry vision. Ophthalmology sent him in after they noted he had 20/70 vision in that left eye with grade 2 edema. No other systemic symptoms. His exam was notable for a partial left sixth and a proptotic eye with mild ptosis. Who do we have here? Let me see. David, you're on, or Adham? I guess not. Damien. Oh, who's that?
Yeah, I'm here.
Oh, Dame. Hey. All right, man. So where are you thinking I guess what would you want to get part of your workup?
Well, yeah, I'm concerned, given the visual symptoms, it seems to me like it could be an orbital lesion, or versus something kind of similar we just talked about. But, I'd want to get an MRI of the brain and probably the orbits as well. To take a look for, lesion.
Okay. First thing that you get is a CT scan. What do you see in here?
A very large, pretty well circumscribed lesion in like the left orbit, lateral orbit. Likely the cause of his symptoms, obviously. But it kind of explains the sixth, given its like proximity to lateral rectus there, and definitely would need an MRI now to kind of figure out what it is. But it looks like it's eroding the bone.
Yeah.
It does look like it could be a meningioma, just given kind of some of those features, and it's pretty well circumscribed. But definitely would get an MRI and also consult.
Exactly. And here's the MRI you ordered. What do you? Anything else to add to what you saw? You've kind of mentioned a lot of things.
Yeah, not really. I mean, again, pretty homogeneously enhancing lesion. Looks like it's a meningioma. Looks like it's arising kind of from the dura there. I don't really see a dural tail exactly, but it kind of looks like it's got that appearance.
Okay, perfect. And I don't know if I have another scan. And then here, what sequence is this? I'm just thinking for someone who's immunocompromised, comes in slightly altered, uncooperative.
Yeah, I mean, it could be like it looks like a DWI. It could be like an abscess or something.
Exactly. One of those things that you just don't want to sit on, especially if it's that large. So what's on your differential?
So like meningioma, it could be like a say meningioma. It could be like an orbital lesion, kind of, or even a schwannoma, and could be infection, but less likely. Lymphoma, I guess, could always be in this area too, or some of the kind of unusual inflammatory orbital apex lesions, but probably much lower on the differential. Okay.
Yeah, that was a broad differential. So a couple other things to add. Maybe we talked about the abscess, a metastatic lesion, or plasmacytoma. So given its location, kind of the zygoma, the lateral part of the orbit, what approach would you take for resecting it?
I mean, like a left-sided, like cranial-orbital approach. We probably have ophthalmology available as well. It looks like it's pretty much, pretty deep within the orbit. And so you can kind of like unroof the orbit to be able to kind of see into it and take out as much of the mass as you can. I mean, it's pretty well circumscribed, so hopefully you'd be able to get all of it out.
Sure. All right. So just quickly on OZs. So sort of kind of what you're talking about. So OZ is basically like a large pterional where you involve the zygoma and the lateral and superior parts of the orbit. And what that allows you to do is it gets you a better subfrontal approach and also minimizes brain retraction. You can kind of see the lesion where it's kind of eroded in that lateral aspect. It's kind of given you that window already.
Thank you.
So, and I'll let Dr. Saad take over for the path slides here.
Thank you very much. So this is the tumor. Obviously, it's very cellular. And some of the cells, there is this one in the center, has what we call a plasmacytoid appearance, meaning the nucleus is pushed to the periphery and the cytoplasm is a little bit larger and there is some clearing in the cytoplasm. In the pathology world, we think that this clearing is due to immunoglobulin secretion. And here you can see the paranuclear huff that is also most likely represent immunoglobulin secretion. So every time we see this picture, this is more of the plasmacytoid appearance and some anaplastic features. Every time we see this huff or paranuclear clearing, we think of plasma cells. Ki-67 is very high, is about 85%. So this is a high-grade malignant neoplasm. CD138, which is a plasma cell marker, is diffusely positive. So now that we established that these are plasma cells, we need to make sure they're clonal. And we do that through kappa and lambda. So this tumor was kappa restricted, meaning it was diffusely positive for kappa, negative for lambda. So this is plasmacytoma. Of course, we cannot call it multiple myeloma since we need additional laboratory and imaging features. But as it stands, this is a plasmacytoma.
Thank you, Dr. Saad. Let me take over here. All right, so Dr. Saad went over these slides already. And like you said, diagnosis here is plasmacytoma. And he also hit it in the fact that plasmacytoma is kind of on the spectrum of multiple myeloma, where plasmacytoma is the one lesion versus diffuse involvement with multiple myeloma. So incidence is 1 to 2 every 100,000 of multiple myeloma. It's actually twice as high in African Americans. It makes up 1% of all malignancies and 10% of all blood cancers. And like this patient, the demographic is 60 to 70-year-olds with a male predominance. So he was, I think, like a 60-year-old male. Damien, I have him here, but just so workup in this case, I'll just tell you. So benzoic proteins, you look at it. You look at the UPEP and the SPEP in particular. For multiple myeloma, you're looking for what's called the M spike. You can get a skeletal survey to look for the pathognomonic punched out lesions. And in general, they tend to be at the site of red bone marrow. So obviously we see them a lot when they involve the skull and the spine because of the marrow type there. And additionally, part of the workup is to get a bone marrow biopsy. In general, the treatment is medical with med-onc and rad-onc. We get involved when we need radiotherapy and or like a percutaneous kyphoplasty or something along those lines. So plasmacytoma, like we said, is a single clone of those cells, one lesion. There's no actually myeloma on the biopsy, and there's no M spike. But multiple myeloma will develop in 50 to 60% of these patients within 5 years and 70 to 80 within 10 years. And plasmacytoma that actually involves the skull actually doesn't really cause neural symptoms in the sense of altered sensorium or altered mental status, but you do have cranial nerve palsies because of the skull base involvement. And just like this guy's case, with that six nerve palsy and proptosis as well, because of the space occupying component of it. So third case.
James, just two comments on those first two cases. You know, so the first guy, you know, he was actually enrolled in a meningioma 5-ALA trial, and interestingly, the 5-ALA was patchy on when we were looking at the tumor, indicating that there was some irregularity in the tumor, and so not enough to say that there was two tumors in there, but I thought that was interesting. Even though Mets can be 5-ALA positive, it was kind of like indeterminate. So still out there whether or not 5-ALA is useful in meningiomas, but hopefully the trial will let us know. And the second one, you know, when you look at the MRI and the CT scan, this one was a lot of bony erosion, which would be typically much different than a meningioma. So when you're looking at these bony bone type kind of masses, you know, remember meningiomas will call hyperostosis, not lytic lesions like this. So a lytic lesion like this, you're thinking unlikely meningioma, more likely either something else like lymphoma or plasmacytoma or MET, which kind of gave it away. These tumors are very, very soft. So, you know, even at the time of biopsy, it was kind of already, you know, once you're in it for kind of the whole tumor resection, which is what we ended up doing. And then the other point you brought up is, you know, when do you bring in you know, oculoplastics into these cases? And I think, you know, if you get good radiology preoperatively and the tumor doesn't involve a lateral rectus and just kind of the periorbital and periorbital fat, I tend to do it myself. But if it goes beyond that into the lateral rectus, that's when I start trying to get oculoplastics involved.
Got it. Okay, perfect. Thanks, Dr. Ivan. So we'll go to the third case, which is a case of a 50-year-old female, past medical distant history of breast cancer, was treated with chemo, but did not have any surgery, radiation, didn't have any follow-up, presented with visual decline over months, and has a history of cocaine use. This is actually our exam when the patient showed up into the ER. She was altered, waxing and waning mental status. She was full strength, but really the biggest thing was that, you know, she had not really cooperative with a real neuro exam. Who do I have here? Adham, are you around, man? No? David? All right. Sumed?
Hey, what's up, man?
Hey, buddy. All right. This patient's in the ER. What do you see? What are you seeing here on the CT scan?
I'm seeing a brain, maybe slightly hyperdense more than brain mass lesion. That seems to be both stellar, suprasellar, extending past relatively laterally as well, near the hypothalamus. Also would be, yeah, I would say that I'd get an MRI, so like a formal visual exam, exam from ophthalmology to look for the papilledema as well for this gentleman or this lady, and then also an MRI brain with a stellar protocol.
Okay. And anything else?
Yeah, I'd get all the pituitary, pituitary macroadenoma labs or microadenoma labs as well. It's a macro if it's going to be, but yeah.
All right. So like you said, so labs, additional imaging, and then adding to the opto consult, you know, maybe getting endocrine on board early, just to see what they have post-operatively too, if the patient has any issues. So just as a quick reminder, I know a lot of us have went through all of this already. So for the pituitary labs, that mnemonic flat pig, where you're looking for FSH, LH, ACTH, TSH, prolactin, IGF, and growth factor. In this patient's case, here's the hormone profile. Relatively, the biggest thing here was that prolactin was negative, sodium was 150, and the patient's drug screen they were positive for cocaine. So Do you have any more targeted questions you'd want to ask this patient, Sumed?
Yeah, the questions targetedly I'd want to ask is one, severe headache or any changes acutely in vision to rule out something like apoplexy.
Perfect.
I'd also want to know. Oh, sorry. Oh yeah, I'd also want to know. I guess what other kind of like, you know, obviously past medical history. If they've had any headaches they're experiencing that are related to position. I didn't really see any hydra on that scan, but you know that's always a consideration for me when looking at these tumors. Any other endocrine kind of manifestations, like is like, you know, any they notice that their back is more humpy than normal?
Exactly. You hit the stuff. So it was ruling out the emergent stuff, which would be, like you said, apoplexy, and obviously that's a combination of their exam and, you know, the imaging, and then kind of the more of the chronic stuff that you may see with these supercellular lesions, the hormonal things, like you said. In this case, relatively unremarkable. And you mentioned getting an ophtho consult. Really, in this case, the patient's left eye vision, the visual acuity was 2200, but weren't able to check for visual fields. And what visual field would you expect with the lesion here?
With a lesion like that, I'd expect the bitemporal hemianopsia. Like,
exactly. And so here's the MRI that you ordered. Anything? Go ahead and describe it in like sequence and cuts.
Yeah. So this is MRI axial and sagittal with contrast, T1 with contrast. It looks like there's a relatively homogeneously enhancing lesion that's in the supercellular region, with a little bit of kind of what looks like maybe more kind of hyper intensity enhancement around the periphery, kind of superiorly. It extends. I can't really see the carotid. I can see maybe some of the carotid on the right side, but it really kind of extends laterally towards the carotids there. And then it's not as like, I could convince myself potentially that there's like a little tail where the tuberculum would be, but I would say that's kind of more so like just like androgen differential for me.
Okay. All right. And then if I showed you these sequences on that same MRI, or these slices on that same MRI, multiple sub-centimeter lesions.
I would be thinking, yeah. So now my differential kind of changes towards like metastasis. Versus just kind of like a macroadenoma, meningioma, or craniopharyngioma. Like those are the things I'd be thinking of prior. Maybe lymphoma also can now is like in the differential. For me, she uses cocaine. Maybe she's I don't know. Maybe she also has like drug use as well. So maybe lymphoma you never touch for HIV. I think there's like those yeah, that'd be my primary differential for this now.
Perfect. You hit on a lot of things, and I'm sure we all remember that mnemonic SACHMO, which helps remember or helps organize the differential for those things in the cellar or supercellular region. So you hit a lot of them. So sarcoid, aneurysm, those other things, teratoma, tuberculosis. You talked about cranio, Rathke's cleft cyst. An additional, if it involved more of the clivus, you would think chordoma. Always think of the hypothalamic glioma, histiocytosis. You talked about the possibility of meningioma and Mets, and then lastly, the optic nerve gliomas. So how would you go about trying to resect this?
I think for this one, you can probably get a pretty decent resection. The endoscopic the transsphenoidal approach for this. You have like a straight shot back towards some more of the superior stuff. And I don't think it really extends far lateral that you couldn't reach that with just an endoscopic approach.
Perfect. So that's exactly what was done in this case. So the intraoperatively, it sounds like the intercellular components were mixed. Some portions of it were very soft and others of it were very fibrous. And then when they were doing the resection, it looks like there was no connection between the cellular and the supercellular components of the tumor. So at that point, you make a decision of whether you're going to open up the diaphragmatic sella or not when you don't know what the pathology is. So in this case, a combination of things on the way in helped make the decision of, to to wait for the final pathology. And those things were that with exposure of the septal flap, it was poor tissue quality because of the patient's history of cocaine use. And that would make it very high risk for a CSF leak later on down the road if they went for a more extensive resection. And so based on that and the fact they didn't know exactly what the pathology was, they said, all right, let's just send this off and see what it shows. So while they waited for that, once that final pathology came back, and I'll let Dr. Saad talk about in a second, the decision was that since the patient was still having obviously having visual complaints, this lesion, and that the supracellular components weren't connected, to do a transcranial approach as well after the final path from the first stage came back. So the second stage was a transcranial approach, and intraoperatively, it was found that the tumor was very firm and fibrous, and like you mentioned, Sumedh, it actually, on the slices you couldn't really see it, but on the left, it encased a lot of the neurovascular structures. So I'll let Dr. Saad go into the pathology at this time.
Thank you very much. Oops, for some reason it keeps going to the first slide. Let's see. Okay, so this is the tumor at low magnification. This is a pituitary adenoma. So you can see the loss of the architecture of the pituitary gland. And this is the collagen 4, which is thing that we apply to highlight the loss of the nesting architecture of the pituitary. So here at the periphery, there is a little bit of residual normal pituitary gland, and you can appreciate the nesting, the normal nesting pattern of the pituitary gland. And next to it, you have a complete loss of the collagen 4 fibers. You see some collagen 4 fibers here in the blood vessels, but none within the stroma of the adenoma. However, if you look carefully, you start to see cells that are different. First of all, the tumor is mitotically very active, which is a red flag in pathology, because unless we are dealing with a full-blown pituitary carcinoma, you rarely see mitosis. And if you do see them, it's usually 1 or 2 per 10 high power field. Here we have 3 per 1 high power field, so that's very high. Also, the tumor cells are different than the pituicytes. Remember, pituicytes, we use the term salt and pepper chromatin pattern, meaning it's a neuroendocrine differentiation. Here you have pretty much granular chromatin and very large nucleolus. So cytologically, they're different. And given the patient's history of breast cancer, we did do GCDFP15, which is a mammary epithelium marker. It identified few cells, but mammaglobin, which is a more specific marker, shows scattered tumor cells of mammary origin within the adenoma. So this is a metastatic breast carcinoma to a nil cell pituitary adenoma. We did all the transcription factors, TPIT, PIT1, and SF1, and they're negative. That's why we called it nil cell.
You're still muted.
James, you mute again.
Yeah, perfect. Sorry. So the stage 1 path came back as adenoma, and after that path came back, the decision was made to go in and do the transcranial approach. And Dr. Saad let us know what the diagnosis was. So we touched on a lot of these things, Sumedh, as really when you're thinking of cellular and supracellular lesions, too big, like the big fork in the road is functioning versus non-functioning. We talked about the presentation. You look for the hormonal disbalance, visual field deficits. You said bitemporal hemianopsia you would look for, and most importantly, the apoplectic event. And the treatment for that is the glucocorticoids. And we touched base about the workup and postoperative considerations as well too. So in this case, nil cell pituitary adenoma, I hadn't heard of them, but Dr. Saad told us kind of what it was. It's a pituitary adenoma that has no evidence of a specific cell lineage, and in order by either IHC or transcription factors. So they have other names, which include hormone immune negative adenomas or transcription factor immune negative adenomas. Then they're actually relatively rare. Less than 5% of all non-functioning adenomas, and microscopically, they're composed of the chromophobic cells, which is negative PAS, and they grow in the cords of the sheets, like cords or solid sheets. And IHC wise, they lack all the hormones and the transcription factors, like we said, hence the name, but they're positive for cytokeratins. Despite their kind of relatively aggressive features biologically, they're actually, after a good resection, they actually have a good prognosis overall compared to the other non-functioning subtypes. So case 4, we have Vignesh, you around?
Yep, I'm here.
Okay, perfect, man. This is a case, 37-year-old female, history of a cervical tumor, was resected back in 2016 and was last seen in February of 2016 and was last seen in our clinic in October of 2016. Unfortunately, she was lost to follow-up, but after her surgery and at that post-op visit, those 8-month post-op visit, she was actually doing really well. She had some residual numbness in her 4th and 5th digits on the left hand and had been doing fine up until a week prior to presentation. At that point, she started having neck pain going down into both her traps, but no pain shooting down the arms. She says the pain in the neck and the traps was 10 out of 10 and does well with the ibuprofen, which gets to about 4 out of 10. But also she has noticed that she's chronically had the 4th and 5th numbness, but now she has numbness in her left middle finger. No bowel or bladder issues, no balance or dexterity problems. And this was her scan pre-op back in 2016. Can you describe it for me, man?
Yeah, sure. So on the T2, well, on the T2 and the T1 contrast sequence, it looks like she has an intradural intramedullary tumor from pretty much taking up the entire diameter of the canal in the lower cervical spine.
Perfect, man. So, and then this right here is the post-op scan at 8 months post-op. So what do you see here?
So it looks like at least the cord is significantly decompressed there. There may be some, residual, along the central canal, which causes, what it looks like, some almost like a syrinx above and below. Either that or maybe it's just space from the residual, from the resection.
Yeah, exactly. And so at our last exam in October of 2016, most notable things on her exam, she had brisk reflexes and a positive Hoffman on the left. She was actually full strength in the uppers and lowers. And then when she represented after this 1 week of worsening symptoms, she's had now 3 out of 5 in her left hand intrinsics, and she has diminished sensation to touch in that left 4th and 5th digit. Whereas before, though she had numbness, she still had that equal sensation to light touch. And she's had her stable brisk reflexes in the left-sided Hoffmans. And so now in this case, obviously, I'm assuming your answer is going to be to re-image the patient after they've been lost to follow-up for all these years. And you get this. What do you see here?
So looks like the that intramedullary mass has gotten bigger, causes like CSF obstruction at that level of flow in the cervical spine, causing a syrinx above and below, above that level where the tumor is.
Okay. This thing that you keep calling a syrinx, do you know another name for it?
No, I'm not sure.
They're sometimes called polar cysts.
Oh, gotcha. I see.
Yeah. So what would you do in this case? You have a patient that's had a cervical cord tumor, which was lost to follow-up. Looks like it's basically regrown. What would you do? I guess first, what's your differential, and then what would you do?
Yeah. So, she has some type of intramedullary tumor with this cyst associated with it. differential would be, ependymoma, and then, that would be, I think, at least based on its location, I would be thinking. And then I guess in terms of the further management, she's symptomatic from it. So I think, you'd have to go back in and re-resect, as much as possible. Maybe if you would have to leave some sort of like cysto-subarachnoid shunt or something to at least, alleviate the pressure from that polar cyst, that might help her symptoms as well.
Okay. So do you have kind of like an architecture when you're thinking of these differentials for these things? I'm sure you do. And it's something that we've all kind of been, it's kind of beaten into us. So really when it comes to spinal cord or spine tumors, three main categories. You think of intramedullary, intradural, extramedullary, intradural, and then extradural. So just to kind of broaden the differential a little bit, obviously in this case, we would know what the path is after the first surgery, but like you said, perfect. Appendamoma is one of those things. Another thing you'd also consider is an astrocytoma. Those tend to be more infiltrative within the spinal cord. You have the hemangioblastomas as well too. Intradural but extramedullary, that's our nerve sheath tumors, things like that, meningiomas. And then completely extradural, you think of the bony tumors. And so just like you said, man, the decision was made to, you have to go back in and resect. The patient underwent a C5 to T1 revision LAMI for re-exploration and re-resection. And I'll let Dr. Saad take over for the pathology.
Hey, James, just before we get to the pathology, just to go over the thinking here. So when we saw her 6 years ago post-op, she had, probably 5–10% residual tumor. I can't remember what the original pathology was. I believe it was ependymoma. And then the decision is, do you watch it or, radiate it? Typically I just watch them but watch them closely. She was obviously lost to follow-up. And so then when she comes back, then the question is, do you operate versus radiate? When they're so big with such a large syrinx, the best thing to do would be to operate and try to get a 100% resection. And then depending on the path, which Dr. Saad will show us, we'll determine if it's completely benign, we'd probably just continue to follow. But if it had malignant features, probably radiate. Why have a residual? Typically it's either because, we either miss a little piece or, during resection, we have significant changes in the motors. And if that is the case, then it's better to leave a small residual rather than creating a neuro deficit. And you can see she was pretty motor intact post-op. So that was the thinking behind how to manage her. So Dr. Saad will let us know benign versus malignant.
Okay, thank you. So this is the tumor at low magnification. This is what we call the Ependymal Pseudorosette. So you have tumor cells that are palisaded around a blood vessel, and you can see the processes that are coming out of the, it's better seen here, coming out of the wall of the blood vessel into the perivascular tumor cells. We call it pseudorosette as opposed to true rosette, where the center of the rosette is actually formed of neuropil as opposed to blood vessel in pseudorosette. And this is higher magnification. You'd see the tumor cells show minimally TPN pleomorphism. This is again ependymal pseudorosette, and this is the blood vessel. GFAP is very helpful. So this is ependymoma, very helpful in ependymoma because it highlights the processes that I just highlighted to you between the outer surface of the blood vessel and the tumor cells. And EMA, which is an epithelial marker, but in ependymomas, it has this characteristic dot-like intracytoplasmic positivity, which is thought to represent intracytoplasmic lumina, characteristic of ependymal cells. Ki67 is low, reaching a maximum of 2%. So this is an ependymoma at grade 2.
Thank you, Dr. Saad. So let me go back here. Oh yeah, I don't think I'm on mute this time. All right, so Dr. Saad went over these, and diagnosis was grade 2 appendamoma. So appendamomas, obviously they can be seen anywhere in the neural axis. Intracranially, they arise from the ependymal cells of the ventricles, and from the spine, they arise from the central canal. In general, they're slow growing. They're usually benign. They have a slight male predominance. An important thing in the workup is to image the entire neural axis to make sure that you're seeing any of them. And those things, Vignesh, that you talked about, the cysts, like you talked about, they were polar cysts. In general, from what I've read, is once you actually resected the tumor, they resolve over time. It's not like you need to go and treat the cyst. You resect the tumor and the cyst kind of absolves over time. Appendamomas themselves account for 60% of spinal cord gliomas. 96% of them occur in adults, 50% in cervical spine, and the other 50% are the conus. And those are the ones that we term myxopapillary ependymomas. And Dr. Levy actually hit all the stuff in terms of treatment, is that gross total resection is generally the treatment of choice with no need for post-operative radiation therapy. But, like you mentioned, those couple things of residual, watching it over time, hopefully the patient comes back for follow-up, or if there is a recurrence, the need to re-resect in the setting that is actually a relatively lower grade ependymoma. Dr. Saad talked about these, the ependymomas, that in general, they're usually benign, but sometimes, like Dr. Levy was saying, they may be invasive. For these grade 2 ependymomas, there's 4 main variants. The most classic is the papillary one, and that has the perivascular pseudorosettes that Dr. Saad had pointed out. The other 3 are cellular, clear cell, and tansitic, I think it's pronounced. So I think with that, that's all the cases for today. Thanks, guys. I don't know if you have any questions or comments or anything. If not, I guess, Iggy, I think it's Josh, maybe next.
Okay, stand by.
Okay, thank you, everyone. Have a good day.
Thank you, guys.
Good day.
Okay, bye-bye.
Thank you, James. Thank you, Dr. Saad.
Thank you.
Okay, are we taking a break or should we get started?
Definitely, let's get started.
Awesome. Okay, so if anybody's on that doesn't know, I'm Josh Burks, one of the 5th-year neurosurgery residents. I've been doing a enfolded neurointerventional year this year, coming up on the end of the fellowship. I wanted to talk a little bit about stroke today because when I started this fellowship about a year ago, I realized how little I actually knew about stroke in terms of how how we triage stroke and in what ways we can treat stroke. And I think there's some pretty exciting things, innovations that are coming in stroke that I want to talk on as well. So, I think that this is kind of my everything you should know about stroke if you're doing neurointervention. Probably a gross oversimplification. If there's any neurologists watching, I apologize, but trying to keep it simple for the neurosurgeons watching. So, like I said, our objectives are going to be understanding what the workup and triage is for stroke and specifically for LVO, since that's what we can treat as interventionists. I want to talk a little bit about the techniques that we use to do this, the limitations of those techniques, and then, as I said, some future directions. So broadly, when we're talking about stroke, the two types of stroke people tend to think of are hemorrhagic versus ischemic, and those classifications aren't very helpful from a treatment or intervention standpoint, because there's multiple etiologies of each type of stroke. Ischemic stroke could be from a dissection, from an embolism, from a hemorrhage, from a tumor. Those things are all going to be treated differently. Hemorrhagic stroke, similarly, aneurysm, AVM, fistula, amyloid, all very different treatments. There's also a lot of pathologies of stroke that we don't think about as much in neurosurgery because we just don't see it. We do a lot of angiograms, for instance, for patients with different vasculitis, either autoimmune or infectious, and that's a common cause of stroke. COVID-19 has caused a lot of strokes, and we've done a lot of thrombectomies in COVID-19 positive patients this year. Obviously, there's genetic and factors and hypercoagulabilities that people are born with as well. But we're mainly for this talk going to focus on ischemic stroke, and I think it's helpful to think about ischemic stroke in terms of it being the most common cause of stroke. You know, we in neurosurgery focus a lot on subarachnoid hemorrhage, related to aneurysms, AVMs, and it's helpful to think about how small of a percentage that actually represents within stroke. This is a study from a representative population in Europe that basically shows, in terms of all vascular events, coronary events are the most common, and then after that, it's ischemic stroke. And you can see in this subset, for instance, you have 550 patients that had an ischemic stroke, and only 27 of those were subarachnoid hemorrhage. So there's a lot more people that have strokes and aneurysms. History of stroke goes a long way back because it's one of the most recognizable conditions of someone, particularly if someone has a large stroke. It's not like some insidious process that could go on months and months without being diagnosed. Particularly if it's a large vessel occlusion, it's usually not subtle, and pretty much all of us know someone, or at least know of someone who's had a stroke. So stroke incidence in Western populations has been on the decline. People have pointed to use of anticoagulants for patients at risk, and also a reduction in cigarette use. So just a little more on the prevalence of stroke. Around 15 million people worldwide, and within the U.S., close to 800,000 people have a new or a first-time stroke. And as I said, the vast majority of these are ischemic strokes. This particular source said about 240,000 of those, or about a third, are related to large vessel occlusion. Those numbers vary quite a bit, and I'll come back to that. So this shows what at the bottom left, this figure shows what the mortality rates are from stroke per 100,000 people. And I think that the main takeaway here is that the morbidity of any stroke is actually high. So if you just look at the total population of people who've had a stroke, about half will live less than a year. And 2/3 of strokes occur in people older than 65. And so I mentioned earlier in the study I showed before, about a third of patients with stroke had a large vessel occlusion. The meta-analysis have been done on this, and the rates vary from 7 to 60%. Anecdotally, it seems like, at least at our institution, probably around 20 or 30% of the strokes, ischemic strokes that come in, have a large vessel occlusion on CTA scan. But this could also be influenced by a number of other things depending on different characteristics in the population. Different populations are going to have different risk factors and different levels of access to healthcare. And I think a great question, and something we probably all ask ourselves at times is why are we intervening for stroke? Why do we treat stroke? And it's really interesting, actually, kind of looking at the history of treating stroke with endovascular techniques. The first 3 major trials that were published in the early 2010s actually failed to show that there was a benefit to endovascular thrombectomy. Those studies were mainly using the Mercy stent retriever, which is at the bottom right. Subsequently, the Solitaire, which is made by Medtronic, was used and is still probably the most commonly used stent retriever. It seems to work a lot better, and I think that's why things changed in terms of the way we think about treating stroke. So 2 years after that, there were 5 trials published almost simultaneously that essentially showed that patients treated for anterior circulation, large vessel occlusion, had an improved functional outcome. And it's a pretty large improvement in these studies. I put up a couple that are well known. Just for an example, Escape and Mr. Clean, you had about half with functional independence compared to 23% in the Escape trial, and similarly in Mr. Clean, you had almost double the number of people that were functionally independent at 3-month follow-up. Additional meta-analyses were done of these trials that were published and confirmed this. And so now for anterior circulation, endovascular thrombectomy is definitely the gold standard. And this is a nice summary of those trials and basically everything that came out since that time. I would direct our attention to the column, specifically the 2 columns that say the NIHSS requirement and the time from onset. So those all vary and got more generous as time went on. And specifically the 2 at the bottom, the Dawn and Diffuse, were studies that showed that if you use perfusion imaging to help determine candidacy, that you can actually improve outcomes out to 16 and 24 hours. And that's had a big impact on who we treat at our institution. And so now all of these studies are for anterior circulation. So that means it's a branch of the carotid. It's either proximal or distal internal carotid artery occlusion, or most of the time an MCA occlusion. So in terms of treating posterior circulation occlusion, meaning basilar or proximal PCA, does not have the evidence that anterior circulation does. There was one trial called the BASICS trial that was published about 5 years ago that failed to show a significant difference in functional outcomes. There were some critiques of the trial in terms of who was included. There's been some non-randomized trials that have shown good outcomes with treating posterior circulation strokes. I think, we've been pretty aggressive in treating these with intervention because essentially with the basilar occlusion, that's a non-recoverable stroke if nothing's done. And we've certainly had some good outcomes in treating those patients. So being able to stratify who is going to benefit versus who isn't, I think, is going to be the key there to showing that intervention for basilar occlusion is worthwhile. And there's a group that's doing that now. They haven't published on this yet, but they released their results a little earlier this spring, where they have definitively shown that intervening for basilar occlusion is beneficial. I think there's two things that they do in this trial that kind of align with what we've done that's been working at our institution. And that's number one, they place a stent where there's a clear intimal pathology. And I think in basilar occlusion particularly, there often is. And they exclude patients with extensive tortuosity and who aren't like generally healthy at baseline. So I think that intervening for posterior circulation strokes will also be, or is already kind of becoming standard of care. And finally, you know, a lot of countries now, including those that are have public healthcare systems, are pushing for intervention for stroke, because there's a significant reduction in the financial burden associated with stroke with thrombectomy, because by improving these functional outcomes, you know, even though there's a higher procedural cost up front, the lifetime savings in therapy and in the assistance that those patients more than worth it. So I want to go through kind of what some of our workup in triage is at our institution. I think that's fairly standardized. So first of all, I just learned all this year and why this is important. There's the Joint Commission has 4 levels of certification for hospitals. The highest level is the Comprehensive Stroke Center. That's what Jackson is. And then there's thrombectomy capable stroke centers, which I believe is what UMH is. And then all the way down to just acute stroke ready hospital, which I think essentially means that like a neurologist is available through telemedicine to assess a patient and help determine eligibility for Tpa administration. So there's a few reasons this is important. I thought initially that the Joint Commission just kind of served to make sure the nurses threw away your coffee and hid your lead from you when they were in town to visit. But this certification is actually really important because it has to do with how EMS routes stroke patients and also federal reimbursement for the hospital. And, you know, even if you're not trying to bring in more strokes to your hospital, the ruptured aneurysms and ABMs and all types of neurovascular cases are going to go where the strokes are going. So maintaining that certification is actually really important to the program. So this is our workflow when there's a stroke. Basically, the patient arrives in the ED. Sometimes we've had a pre-arrival notification, meaning they called from EMS and thought they had someone with a stroke. The patient's evaluated in the ER by a neurology resident. And if they think that the clinical picture looks like it could be a large vessel occlusion, then they call us and we activate our team. And from there, they go to CTA, which usually takes about 30 or 40 minutes, which gives everyone enough time to get to the angio suite. So then if there is a confirmed occlusion on the CTA, then everything is ready to go for the thrombectomy. And this is all kind of structured around the metrics that are set by the Joint Commission. So, you know, some of these don't apply to us as much as the interventionalist. TPA is done in the ER. The symptoms are assessed in the ER. But what we really care about is the door to puncture time and the puncture to reperfusion time. So, by alerting the team, just kind of based on the clinical picture, it's very doable for us to be starting the procedure within 90 minutes, and then working towards getting reperfusion in less than an hour. So when patients are en route to the ER with a suspected stroke, they give us a fast ED score. And this is helpful because it gives us an idea how likely this is to be a real stroke. And this is a score that's been validated. Basically, if it's a score from 4 to 6, it's a reasonable possibility, 30 or 40% chance that there'll be large vessel occlusion. If it's higher than that, it seems like, and this isn't in the literature, but it's usually some type of hemorrhage. And if it's lower than that, then the likelihood of an LVO is much lower. But it's based on basic aspects of neuroexam. And like I talked about in our indications for these, the last known well is an important metric, because we say we're treating out to 24 hours or knowing whether we need to get a perfusion study. We generally assume, if we don't know the last known well, that it was less than 24 hours ago, and get perfusion imaging. And frequently we don't know the last known well. In the ER, the patients are, as I said, assessed by some member of the neurology team, and they assign an NIH stroke scale score. It's basically a full neurological exam, and they use this form here on the right, having the patients describe what's going on in the pictures, name objects in the pictures, read sentences that are on the form. Less than 6 is pretty mild. Mild stroke, that's usually would be something like some facial droop and maybe arm drift. And if those are the only symptoms, then we generally don't want to assume the risk of taking them for a thrombectomy. 6 to 17 is going to be moderate disability, and then 17 over 17 is usually a non-survivable stroke. So anything over 6 is going to be something we consider for intervention. We also look at the aspect score. So basically, these regions that are highlighted here are each assigned points. And if they're not clearly affected by the stroke, blurring of the gray-white junction, loss of soul psi, hypodensity, right? The things that look like stroke, then they lose a point. So you want the aspect score to be higher. So you want it to be higher than 6. That tells you that there's tissue there to be saved. I used to think it was kind of voodoo, this dense MCA sign, but it's actually true on the plain CT. In some of these cases, you can really see that the clot is hyperdense, so the surrounding tissue can also be a good tip off that you should start heading in for the case. And then of course, this is a pretty common CTA. Most of the cases we do are MCA occlusion. So that's what we're looking for. And I mentioned perfusion. So if it's been more than 6 hours, we get a perfusion study on these patients. Just a quick review of what the CTP is. The 4 types of CTP images you look at are the TTP, CBF, CBV, and MTT. So just like I try to keep this really simple so I don't get them confused. TTP, you just kind of compare the 2 hemispheres, and you'll see if there's some gross difference between the 2 in terms of perfusion. The cerebral blood flow shows you tissue that's at risk. That shows you the tissue that's not being perfused well. Cerebral blood volume. So the dead tissue is not going to show cerebral blood volume. And so that's kind of what you think of as being the core that's already stroked. And then the MTT just kind of shows that tissue compared to the surrounding tissue. So if it's an area that's chronically not getting perfused, then it's not necessarily gonna show up. And so I've got some examples of this that I'm gonna go over later. But the main thing here is the CBF and CBV. You want to compare the blood volume to the blood flow. If there's a big difference between the two, then there's likely a large penumbra there that would indicate doing the procedure. So just kind of recapping the workflow: NIH greater than 6, aspect score greater than 6. If it's been less than 6 hours, then that's a good candidate with a large vessel occlusion. If it's been more than 6 hours and less than 24 hours, then you review the CTP and or MRI. So now I want to kind of just go over some of the techniques that we use in treating stroke, the basics of how we get to these clots. So generally speaking, when you're doing some type of neurointervention, you have what's called a triaxial system, meaning you've got 3 catheters there. So basically, you can see maybe my pointer. Hopefully you guys can see my mouse. So this is a guide catheter. This is kind of a bigger, kind of rigid pipe that sits there and gives you good control over your more distal catheters so that you can do the intervention. And then you're going to have an intermediate catheter, which for strokes is an aspiration catheter, and I'm going to go over what that means. There's then a smaller microcatheter, which is how you get out to things more distally, and this then helps you bring up some of these larger catheters, and then you've got a small wire here that you're driving. And so one thing that's been published on extensively by the group here is using radial access when necessary, femoral access when necessary, and using these things to reduce the amount of time that it takes you to get to a clot. So part of your initial thought process as you're evaluating a patient for thrombectomy is to look at the CTA, look at the coronal study of the neck, and see what the arch type is and what the arch looks like, because you can really save a lot of time getting access and getting your catheters up if you understand that anatomy. So this next figure is a nice example of that. You want to think about the direction of the force vector as you're trying to push your catheters upward into the neck. So, you know, like this is more of a type 3 arch. If your vector is here and it's pushing the catheter down the aorta, you're not going to have a lot of support. You're not going to be able to get a lot of force pushing your catheters up to get across the clot, for instance. Whereas this, which is almost more of a type 1 arch, you can see that when you push, your vector is more going to be here, which is deflecting the catheters up into the brain, giving you more force. So, you know, your access points are either going to be through the arm, through the radial artery, which means you come through the right subclavian, directed into the neck, or from up the aorta from femorally. There's 2 techniques that we mainly use, or I guess there's 3 really that we use to get clots out. One of them is called adapt, and that basically just means that you're driving the aspiration catheter up to the face of the clot, connecting it to a vacuum. You let it sit for a couple of minutes under the vacuum suction, and then pull it out and hope that the clot comes with it. So that's adapt. Yeah, there's the 3 that we're going to go over: adapt, Solumbra, and stent retriever alone, and I'll come back to that. I just included this slide. It's a nice reminder that as you think about aspiration catheters and where the occlusion is, you want to use the largest catheter possible, and that's simple physics. That the larger the lumen of the catheter, the more suction force is going to be applied, and you want the maximum vacuum created by the catheter against the clot to increase your chance of success. So the aspiration catheters that they make keep getting bigger and bigger as people are able to make bigger catheters that can track up more distally and safely. This is an example of a case we did with the basilar artery occlusion, and this was done using ADAPT. So for this case, you basically just use a smaller wire, smaller catheter to get the aspiration catheter close to the basilar, and then just advance the catheter under vacuum suction it over the clot. And you can see the clot there at the bottom right. So one technique is ADAPT. The other is Solumbra, which just comes from Solitaire and Solumbra. Solitaire, as I mentioned earlier, is a type of stent retriever. So the main difference here is that the stent retriever is deployed across the clot, and then the aspiration catheter is brought up to the stent retriever. So you're kind of sandwiching the clot between the stent retriever distally, and then using the vacuum more proximally to pull the clot out. This is an example of a case we did this week using Solumbra. You can see this is the aspiration catheter here. This is the stent retriever here, and this is going right across where this clot is, and it gave us a nice result. So you know, there's always kind of a discussion of whether we should do ADAPT first or Solumbra first. You want to try to get the clot out on the first pass, one, because that's the most likely pass if it's going to come out that you're going to get it on. With each subsequent pass, you're less likely to successfully remove the clot. The other thing is, you know, it saves time if you do ADAPT, because it takes time to deploy a stent retriever. Stent retriever is also expensive. I think, you know, a few $1,000s. So that there's some significant costs associated with using that as well. I think generally we'll try, if it looks favorable, we'll try one pass using ADAPT and then use Solumbra on the second pass. Or if there's something about the clot that was precarious or it was difficult to access the clot, then we'll use Solumbra, because I do think Solumbra gives you just anecdotally gives you a better chance at getting it out on that pass. And then I mentioned there were 3 techniques. The third is where you use the stent retriever alone without the aspiration catheter, and that's just going to be in situations where the anatomy is either too tortuous to bring up the aspiration catheter, or it's too far distal and the catheter is too large. So just going back, like I mentioned, we've got the three systems here. This is, you can barely see a guide catheter, aspiration catheter, and our stent retriever. So the guide catheter, which is this bottom catheter down here, there's different types that can be used. One with a balloon, one without. There's pros and cons to each. You can see if it has a balloon, it just sits down here in the neck, inflated, and that can be nice because it gives you a lot of force, basically, that you can push against if you need to try to get across a clot. It also stops blood from flowing, so as you bring that clot down, there's less risk of it embolizing more distally. The drawbacks are that those catheters tend to be stiffer and harder to pass more distally into the blood vessels. In general, we have just used support guides this year without the balloon, because the support guide catheters have gotten really good and give you a lot of support even without the balloon. And it's much quicker getting those catheters out because they're very trackable. But again, that is at the expense of not having flow arrest for the thrombectomy. So a couple ways that we grade outcomes for patients who've undergone thrombectomy that are standard and easy. good to be familiar with. One is the Tiki Score, and there's three levels basically, and pretty much every case ends up being either a 1, a 2B, or a 3. Sometimes there's a 2A. And a lot of it's just kind of eyeballing the case. If you get the major branches open, but have some medium and small branches still closed, that would be a 2A. If you've got all the large and medium vessels open, but there's some small vessels that are still closed distally, it's a 2B. And if you get full reperfusion, that's 3. So 3 is good. 3 is the goal. 2B is also acceptable. And then the MRS, which is probably familiar, is important both pre and post, because we do look at the MRS scores. We're determining eligibility for intervention. We usually won't intervene if the MRS is higher than 2. MRS at 2 is the important one in all the studies that I showed where they're looking at functional independence. Functional independence was basically defined as an MRS of 2 or better. So MRS is of 2, you're still considered to be able to take care of yourself without assistance, whereas 3 requires assistance for normal living. So I'm going to go through a couple limitations of the techniques that we use, and a couple of situations that come up in strokes to know about. These are important terms that I certainly hadn't heard of before, and now I fear them when I'm doing these cases, because they're you know that you're going to be in for a challenge. These 2 specific pathologies look like any other LVO. The CTA will just look like there's an occlusion either in the ICA or the MCA, and you go in with a plan to do a normal thrombectomy. But as you start the diagnostic imaging, you want to be sure that you recognize if it's one of these 2 scenarios. And so I'm just going to go through a couple of sample cases to kind of illustrate these points and explain what that is. And this was a case that we did recently. Patient with acute onset stroke, left MCA syndrome with the NIH of 14, no filling of the left hemisphere. When we start the diagnostic part, we notice that on the figure on the left, it looks like an occlusion of the ICA. So the arrow is pointing at where the takeoff for the ICA should be. And it's obviously not there. But then the figure on the right shows once we've taken a microcatheter past that site of occlusion and do another injection, it's also not filling more distally. So this is why it's called a tandem occlusion. This means there's a plaque that was probably at the origin of the ICA that's ruptured, occluding the ICA at its origin and also causing a large vessel occlusion at the ICA terminus. And so these are really challenging cases, but they're also really manageable cases. And so our technique on these is usually to try to remove the distal clot first, and then deal with the clot more proximally if we can. In this case, figure on the left is showing we actually the stenosis was so bad at the ICA origin that we couldn't get the aspiration catheter up. So a balloon angioplasty was done. That's shown there on the right. This let us get the aspiration catheter and stent retriever up for a Salumbra pass, which you see there on the left. And this resulted in complete reperfusion. This patient in particular, we brought back and placed a carotid stent a couple days later. The patient did really well. For these cases, they often do require a stent because there's usually significant underlying stenosis, and that's usually done after a day or two to see how the patient does. If they go on to develop a large volume stroke, you wouldn't want to place them on dual antiplatelet therapy for the stent. But as was the case here, that didn't happen, and the patient did well. So those are challenging cases. It's like 3 cases in one, but it's important to recognize tandem occlusion when that occurs. It's a term I'd never heard. Another term that I wasn't familiar with in a second scenario that I wanted to review is ICAD, so intracranial atherosclerotic disease. I'm going to review a case of ICAD. This is one that we just treated yesterday. This was a 67-year-old who had progressive decline in overall mental status, and that's usually the basilar occlusions. That's how they present. It's not like the MCA strokes where it's like a sudden, deterioration. It's usually they'll kind of wake up in the morning and be a little off, and then they progressively just kind of become more obtunded and comatose. So CTA was done, which showed a complete occlusion of the basilar. We took the patient for thrombectomy. On the left is our initial angiogram through the left vertebral artery. And here you can see that the PCAs here are filling. Normally, the basilar just kind of trickles out, and you can barely see it. There's just a tiny channel of it that's still filling. And so this was treated, and this is ICAD. This is what ICAD looks like, and it can occur anywhere. It can occur on the ICA, the MCAs, also commonly, and obviously as here in the basilar. And in this case, we did a balloon angioplasty, and eventually placed a stent, and it's a special type of stent. It's called a balloon mounted stent, and they're actually cardiac stents. And it's basically just what, well, you can see on the far right, good reperfusion, good filling of the basilar there. This patient did really well, regain consciousness. And these stents have made a real difference in how we treat these patients, because the stent's essentially delivered on the balloon. You inflate the balloon, it blows up the vessel and leaves a stent there. And in a lot of ICAD, the intima of the vessel is really diseased. So I think initially we were treating a lot of these with angioplasty alone, meaning just with the balloon, and we were having reocclusion of the vessel. But placing these stents keeps it open, and we've had a really good safety profile using these. There are some significant drawbacks, though, of placing these stents. One is kind of like we talked about with the carotid stents. There's a requirement for dual antiplatelet therapy after you place one of these. So if the patient's already developed a stroke, then there's going to be a really high risk of a reperfusion hemorrhage. The other thing is the stents are stiff. So if the vessels are really, really twisted, it's going to be difficult to get it there. And we're kind of in an interesting place with treating ICAD in general, because in 2013, there was a large-scale trial that was published that essentially was stopped early because the outcomes were so bad in treating ICAD with intervention. The patients treated medically were doing much better, and the mortality was really high associated with interventions. Some drawbacks of that study where they were using a stent called the wingspan. They were also being done at some centers that were not high volume, and the complications were really high, like the rate of rupture and the complications that a lot of reports have had of using balloon mounted stents since then are significantly lower than this study. So there's still not a randomized controlled trial showing that this is beneficial. And we aren't treating ICAD electively, but when people are having an acute stroke and they've failed maximal medical therapy, we've had patients do really well with these stents, like the one on the previous slide. Okay, so those are the two things to recognize. ICAD, you want to know that this isn't an occlusion, and putting an aspiration catheter up is not going to help. Stent retriever here is not going to help, and you want to recognize a tandem occlusion, so that you're not trying to treat proximal or distal when you should be doing the other. The last thing I'm going to touch on here, and we'll be done in just a few minutes, just some of the future directions for interventions for stroke, because I think some of these things are really cool. Some of the future directions are pretty obvious. You know, I don't think you have to understand a lot about stroke to just understand from this talk that the main goals are, you know, faster reperfusion, better reperfusion, and better understanding who should be getting these interventions done. Like I said, especially for posterior occlusions, this hasn't been as well defined, and even the time frame at which we should still be doing thrombectomies is not well defined. This is a list of studies that we're involved in. We're enrolling patients for these studies. There's several registries that we're participating in. One that's particularly interesting we're involved with is Tesla. So that means if it's within 24 hours but of poor aspects, meaning there's already some extensive strokes on the CT, is it beneficial to do a thrombectomy, i.e. do you still improve the outcome by removing the clot even once the tissue has been infarcted, by reducing the inflammation and swelling and so on. Yeah, we're very, very active, very involved here in those studies. The part of improving stroke care, I think, has to do with allocation of resources. You know, a lot of how fast your LVO is going to come out just depends on your proximity to a comprehensive stroke center, which, you know, there's different ways that you can try to address that. You can have more thrombectomy capable centers. Some community hospitals are granting stroke privileges to non-neurointerventionalists to address that. And then obviously just quick recognition of LVO and getting those people where they need to go. You know, the technology is obviously going to continue to improve. It's come a long way in the last few years. None of the catheters that we use now were the same as what we were using even just 2 or 3 years ago. And these procedures become safer, so that changes your risk profile when you're considering who you know, is it more risky to intervene versus not. I mean, as the technology gets better, the risk of intervening continues to go down. Our catheters keep getting softer and safer and more trackable. There's some other things that are really innovative that are happening in different parts of the country. One that's pretty cool are these mobile stroke units. So they actually have these ambulances that have like a full CT scanner inside the ambulance. So, and they're connected by internet to a neurologist. So, you know, the patient can essentially undergo the full ER triage while on the way to the hospital. They can do the CT, the CTA, and get the NIH SS score, the history, and you could have your interventional team ready before the patient even arrives, and that would certainly expedite thrombectomy times. Another would be to have an integrated stroke suite, and this is something that some centers have done as well. Is if essentially next to the ER, you just have a full suite that's capable of CT, angio, and with ready access to EMS. You know, they've done a great job at Jackson streamlining it. Actually, they do get patients very quickly from the ambulance to CT and to angio, but it does still involve, you know, walking walking across the hospital and patient transfers and those types of things obviously take time, particularly with intubated patients. So pretty innovative. And this is something that we use and that's continuing to improve is the mobile technology. There are these apps. We use one called Rapid, where you can look at the imaging on your phone, the same as on PACS, or even better, you can like zoom in really nicely and scroll, and you know, as much as I think a lot of people think we're just sitting at our computers, you know, ready to review stroke images anytime, day or night. It's that actually is true when it's on the phone. Maybe less so when you have to open it on your desktop. There's some really cool stuff and technology that they're putting out and that's being developed. Once you use the robotics, so with the small wires that we use, there's obviously some limitations. You put a shape on the wire before you put it in, and then do your best to guide it in. But they're developing robotic wires that you can essentially use a joystick to steer and drive. This would certainly expedite access in cases with difficult anatomy, or if we were having difficulty crossing a clot. A little less high tech are these catheters, where you can have this little turnstile that you use just to change the how acute the angle is. This is something that's being developed. And then another one that's really cool is actual intravascular imaging. So having a tiny camera that would sit within your microcatheter and let you visualize the vessel wall. You could see if there's you know, residual clot there, or intimal injury, you know, and that could help you decide if you need to stent, if you need to make another pass, if the patient's going to re-occlude. So very cool stuff. These are examples of that at the top. Those are images from the camera, and then those are OCT images of the vessel walls in the lower figures there. So I think we hit all our objectives. Hopefully that's helpful for just at least an overview of kind of what I think is important to know about stroke as interventionalists. Special thanks to the neurointervention attendings and the neurologists we work with, and the team at Jackson. We have a great team there. I'm happy to answer any questions if anyone has any.
All right, Josh, thank you. Great job.
Awesome, thanks.